Dear esteemed members, today Chairperson Dr. Sivaraman, Speaker Dr. Swetha Raghavan, Dr. Ronald Roy, Scientific Committee members, and dear postgraduates, very good evening to all of you. First, I appreciate the Scientific Committee of TNIPS for proudly organizing this enriched webinar. And today we have a very two young speakers, Dr. Swetha Raghavan and Dr. Ronald Roy. Both the young speakers are going to speak about the opioid stimulation therapy and this section of the dissociative disorder in child and adolescents. And also the session is going to chair by Dr. Sivaraman. Dr. Sivaraman is a professor of psychiatry from SR College Hospital from Trichy. With a small introduction, I hand over this session to Dr. Sivaraman. Yes, Dr. Sivaraman, please take over.
Okay. It is a great privilege and honor for me to chair this important statewide Indian Psychiatric Society Tamil Nadu chapter enrich webinar. Though it is a statewide, it is gaining the national importance throughout. Sir is taking this seminar to the national level, and everyone in Indian Psychiatric Society is able to know about the good work what we are doing. I would like to thank our Indian Psychiatric Society Tamil Nadu chapter President Dr. C. Panniselvam sir for providing me this opportunity, and other office bearers as well as the scientific committee for giving me this opportunity to chair this important seminar. So we have two special areas of the psychiatry for this presentation. So one is in the de-addiction area, the other is in the child psychiatry area. Both are emerging areas in our in our field. So usually we used to have talks on alcohol, cannabis, nicotine. All these things are usual. Now we are moving towards an important different topic of opioid use. Though in the coming days we are going to see more of opioid use patients. Okay, the treatment-seeking population of the opioid use patient is gradually increasing. So one area about that. The important things what we are going to see in the opioid is comparing to any other substance use like alcohol, nicotine, or cannabis. In these areas, the treatment is different. Okay, so we don't, for example, for treatment of alcohol, we don't give alcohol as a maintenance therapy. For treatment of cannabis, we don't give cannabis as a therapy. But in case of opioid, it's a different approach to treatment called substituting opioid for the opioid. That is a different concept. So Dr. Swetha Raghavan will be enriching us on this particular area and how to approach those things. The next area we are going to talk about is this deconstruction of dissociative disorder in child and adolescent. So dissociative disorder we usually encounter in our clinical practice. But the challenging in child psychiatry, especially in dissociative disorder, would be means to differentiating between neurological organic cause versus functional cause, because child psychiatry is very important. So in that area, though dissociative disorder is usually we see, but it is challenging to understand about the organic cause, as well as it will be challenging to start any treatment. That is very important. Liaison with neurologists, all these things we are facing very difficulties. So this area would be enlightened by us by Dr. Ronald Roy sir. So next I am going to introduce the speakers. So Dr. Swetha is the first speaker. She has finished her undergraduation in PSG Medical College, post-graduation diploma in psychiatric medicine in Madras Medical College. Followed that, briefly she has worked in Ramachandra Medical College. The second speaker is Dr. Ronald Roy. Ronald Roy sir is finished both undergraduate and postgraduate in Madurai Medical College. And following that, she is currently working in Trichy SRM Medical College. And currently he is working as an associate professor.
Good evening to one and all. Thank you, Professor Dr. Panniselvan. Thank you, Professor Sivaraman, for setting the stage. And my special thanks to Professor Dr. P.P. Kannan, who recommended my name for this session today. So without further ado, I just go straight into the topic, which is opioid substitution therapy. So the scope of this presentation is there are few definitions. We would see the benefits of OST, which is opioid substitution therapy, the phases using BPN separately and using methadone separately, few special situations and take-home messages. So the abbreviations are OST is opioid substitution therapy, IDU is an injecting drug user, DAC is Department of AIDS Control, ODS is opioid dependence, STI is sexually transmitted infection, and NAS is neonatal abstinence syndrome. I'll try to use the elaborative versions as far as possible. So OST is basically a process like where Professor Swetha Raghavan already set the stage for me, saying we don't give alcohol for alcohol, but opioid is a different form of a substance where getting addicted to opioid and getting de-addicted is going to take a long time. So opioid substitution therapy was introduced with the only aim being harm reduction. So these people who are opioid users are IDUs usually, who tend to share needles and hence acquire several infections like HIV, hepatitis C especially, and hence opioid substitution therapy was introduced to reduce the harm of acquiring other comorbid medical issues. So DAC defines an IDU, an injecting drug user, as any person who has used any psychoactive substance in an injecting mode for a non-medical purpose at least once in the past 3 months. The benefits of OST is, of course, the first thing, harm reduction and reduction in the opioid use, reduction in deaths related to overuse, reduction in criminality, domestic violence, and improved family relationships, and improved productivity. And also this, the information that I'm providing is taken from the NACO website. So improved adherence to other treatment like treatment for HIV, tuberculosis, and viral hepatitis. So the steps involved are, first you assess the client suitability for OST, you prepare the person, initiate, maintain, and termination phases. So the first thing is the criteria. The essential criteria is diagnosis of opioid dependence at least for a year, and the individual should be capable of providing an informed consent, and he or she should be willing to follow the procedures of the clinic. So opioid substitution therapy is usually done in OST centers, which are run by the government. Of course, now there are private players who are able to maintain registers for dispensing BPN. So this presentation primarily is based on OST centers. There are certain non-essential criteria like 18 years, of course. Long-term opioid use means at least a year or more. Poor psychosocial functioning, high-risk behaviors like injecting, and failed abstinence attempts in the past. So absolute contraindications, if the person has taken any OST before, any hypersensitivity to the OST contents, and incapability to provide consent. Why it is a contraindication? Because the consent is very, very important, because it is the legal contract between the service provider and the service user, that is the client and the service provider. So that's very important that he or she understands the terms and follows the rules of the OST clinic, like coming in a stipulated time, waiting for a stipulated time, and then leaving. So there are certain rules of the OST clinic which the person should be capable of comprehending and following. Non-essential criteria is like any person, if we have a clinical observation and a proper examination, so lab investigations are not in the standard protocol. We just can proceed with giving an OST, but if the OST center has a facility to do a lab investigation, an LFT would be recommended. So we start with the induction phase. The induction phase is for establishing the first dose. So it lasts somewhere between 3 days to a week, followed by maintenance and then termination. So the goals of the induction phase are, we have to establish a rapport because it's going to be a long-term therapy, at least of a year or more. Determine the correct dose of the substituent that is required, and to address other comorbidities, medical and psychosocial comorbidities. So the OST center doesn't alone have a psychiatrist. The medical officer can be a psychiatrist or an MBBS who is trained for providing OST. And the other workers in the team are a nurse and a social worker. So the induction phase lasts usually for 2 to 3 days, maximum 10 days. So the first dose, before the first dose, the first thing is examine the pupil. If they are constricted, Then you wait, watch this person for every 15 minutes to ensure that the pupil gets dilated before the first dose of BPN is buprenorphine or methadone is needed. So that means that the person doesn't get intoxicated with the opioid that we are given as a substitution for the illicit opioid, which he has already taken. So we'll wait for the dilatation, pupillary dilatation to occur and then administer the first dose. So the first dose starts with a tablet. BPN is a tablet preparation. It is a sublingual tablet. Each tablet is 2 milligrams. So you take one 2 milligram tablet, crush it, put it under the patient's tongue so that the sublingual absorption takes place. Wait for about 30 seconds to 1 minute. Ask the patient to open his mouth, protrude his tongue to ensure that the tablet is dissolved. And then the patient waits for 2 hours. What usually happens is the patient has taken illicit opioid, say yesterday, and now you are giving buprenorphine, which is a partial agonist. So what it does, it goes and blocks the receptors in the brain and it precipitates an acute withdrawal. So once the withdrawal precipitates within the next 2 hours, you can give an add-on dose of another 2 or 4 milligram, wait for the next 2 hours to see if there is a withdrawal. If there is no withdrawal, then you can send back the person home. So on the first day, at least 4 to 6 hour observation period is required, number one. And the maximum dose to be given on the first day is up to 8 milligram, that is 4 tablets of 2 milligram each. So if once the patient is comfortable and you can ask the patient to leave, the person meets us next day on the same time as the last day. Suppose this person has come in at 9 a.m. and you finish giving the first day dose, say around 2 p.m. Then the person comes to us at 2 p.m. Okay. So usually the DTCs, that is the drug treatment clinics, work between say 10 to 4. So we try to fix in patients within that stipulated time. So on day 2, when the person returns, we ask the following questions. Again, pupils are examined, of course. We ask whether this person has taken illicit opioids during this 24-hour interval. The eyes will say if he is intoxicated or if he is in the withdrawal. And if he experienced any withdrawal back in the home or back in the place where he stayed. Well, if he was comfortable, the daily dose is established at the say 6 or 8 milligrams. If he did have withdrawals or if he did take an additional dose of illicit opioid, that means we will again push by 2 or 4 milligrams on the second day. So the second day maximum dose goes up to 12 milligrams. Suppose we have done 8 milligrams on day 1, then another 2 milligrams, which becomes 10 milligrams. Ask the patient to wait for 2 hours. And again, if he's still having the withdrawals, give another 2 milligrams. So that's total 12 milligram maximum for a day 2. Similarly, day 3. Day 3 and beyond, it becomes static. So you already have given, say, 10 to 12 milligram. Usually 10 to 12 milligram for the Indian population is more than enough. And that becomes the ceiling dose, beyond which escalating the dose is not going to give any benefit to the individual. So once the daily dose is established, we go. And on day 3 also, if the person still experienced withdrawals or took a dose of illicit opioids yesterday, that is on day 2, then we still push up the dose to a maximum of 24 milligrams on day 3. So the highest peak level is 24 milligrams. That usually happens with a particular sect of people, which I'll mention in a while. What usually happens is our clients are much more intelligent than we think they are. So what they do is they put it under the tongue. While we are dispensing to another patient, they would comfortably remove it from their mouth, place it somewhere in another place, and they say they'll open their mouth and say that we have already taken the medication, we have swallowed it, and so they then go out, take out the medication from wherever they pocketed it in their mouth, use any container that's available on the roadside, dilute it with some whatever water that is available, take an injection or syringe that they have stored and inject it. This is called diversion. So an oral sublingual preparation is diverted to an intravenous preparation. This happens with the plain BPN preparation that is available. While if we have Suboxone, which is BPN with combination of naloxone, what happens is the moment this person dilutes it intravenously, naloxone being more potent, goes and blocks the brain opioid receptor instantaneously, does not allow the buprenorphine to go and act and show its partial agonism, and precipitates an acute withdrawal. So the person who went with a dose of BPN naloxone outside would come back within half an hour saying, I'm feeling restless, I'm sweating, my pupils are constricted, and I'm like, everybody knows water withdrawals. It's like it's all watering, rhinorrhea, lacrimation, vomiting, and all the orifices are open. And so you see the person in distress. That clearly shows that this person has diverted the oral preparation to an intravenous preparation. So while in India we have a limitation of the availability of Suboxone, its availability is encouraged. Of course, the cost is the constraint with government schemes. So this is methadone. Methadone comes as a syrup of 5 milligram in 1 ml or 10 milligram in 1 ml. The picture shown here is the methadone container. It's a pink colored syrup with the methadone dispenser on the top. It is a very, very carefully calibrated dispenser, which is fixed very carefully. And the blue slider can go up and down so that you calculate the dose. You can lock it in the side. And once locked, what you do is you lift the tubing and press it. It becomes a dispenser. You should have a container for the patient, separate container for each patient. Get the calculated dose of syrup, give it to the patient, ask him or her to drink it. The person waits for like 20 minutes on the day one, and after that it's like a 10-minute wait. They can just sit and leave the chamber. So that's the methadone dispenser, which is available under the NDDTC scheme. Again, the titration lasts with methadone. The titration is a little longer. The induction takes about 2 weeks. While with the oral sublingual buprenorphine, it lasts less than a week. And again, we have to psychoeducate the patient, wait for withdrawals to appear, check the pupils. First day dose, usually the Indian preparation is 5 milligram per ml. So we give about 2 ml on day one, wait for 2 to 3 hours and see if there is a withdrawal, add another 2 ml. And then the maximum dose is like 4 ml, which is 20 milligram. 5 into 4 is 20. So no further dose than 20 milligram on day one. Again, on first day, like I said, for buprenorphine, the maximum dose is 8 milligram. For methadone, it is not more than 30 milligram. And with buprenorphine, we could increase the dose every day. While with methadone, we increase the dose every 3 to 4 days. And as little as I know, methadone is available only under the government schemes. It is not available for private practitioners. So this protocol is taken again from the government MOHFW website. So increase the dose by 5 milligram, that is 1 ml every 3 to 4 days. And maximum increase should not be more than 4 ml in a week. So the maintenance phase is similar to the induction phase. Once you have established a dose, a final dose, say it is 20 milligram of methadone or say 12 milligram of buprenorphine, that dosage is maintained. And ensure that you are maintaining the rapport that is established. Get information about other substance abuse. Make sure that you have rehab services for this person and motivate this person to refer other of his colleagues who are his opioid partners to come and seek help. So the focus during induction phase is to cater to the withdrawals and the craving. While for the maintenance phase, you make sure that the person no longer gets euphoria with illicit medications. So with buprenorphine, it's opioid blockade, while with methadone, it is cross tolerance. That is the mechanism of action. For buprenorphine, the dosage that I mentioned, 2 to 4 takes care of the withdrawals, 4 to 8 takes care of craving, while 8 milligram and above gives the complete blockade that is expected. And again, the same questions you ask, whether the person is taking illicit opioids, and if yes, if he or she is getting any high, then we should push up the BPN or methadone dose. The person should not get any highs with illicit while using OST. So that's the maintenance dose Indian data, 8 to 12 milligrams, usual dose, maximum dose of 20 to 24 milligrams. 20 to 24 milligrams, like I said, goes for particular state people, especially along Goa and Rajasthan, where the purity of the opioid preparations that they get is a little higher. The smack that they get is a little higher. So the higher doses are usually required by Goans or people in Rajasthan who use a particular type of heroin. Once the adequate maintenance dose is achieved, we go to the termination phase. Well, for methadone, the maintenance dose is 40 to 60 milligram. Rarely 90 milligram dose is required. Again, like I mentioned, the same dose should be preferred for maintenance. But in case the person who's taking the OST has resumed some form of physical labor, then we can push up the dose if there is a comorbid additional pain that the person is also undergoing. So usually both BPN and methadone are directly observed treatment, which means the person walks into the clinic, methadone clinic or BPN clinic every day at a stipulated time and takes the dose. What happened during COVID was we couldn't do this because of restrictions. So BPN was given to the individuals and diversion did increase. Methadone in few countries, but for India, was given as bottled doses. There were few instances of toxicity due to overdose, but otherwise, methadone is usually given in India as a daily preparation and as a daily intake. So when the COVID hit, that is the time when we were pressing for Suboxone to be given, but unfortunately, we couldn't manage it. So it's the same for methadone as well. And assessments during follow-up, that is psychosocial assessment, to be done by social workers, are see if he or she is compliant. So there is an attendance register which is maintained by the OST staff. So he or she comes, the person comes, the patient comes, they sign their attendance register, they show their ID cards, their ID is checked, and every person has something called a dose sheet. So the dose sheet is checked, see the previous dosage, the previous dose is dispensed, then the doctor sees whether he or she is having withdrawals, whether we need to increase the dose. And then once the dose is dispensed, the patient stays for 7 to 10 minutes and then leaves the treatment. So the last is the termination phase. While at the termination phase, this is not a mandatory, like disulfiram, we don't know when we terminate. So if the patient wants at the end of say 1.5 years, the patient is very penchant on, having a drug-free life, then that's a criteria for termination. And please understand that the persons can be maintained for months to years without any physical and mental adverse effects. The goals during the termination phase are to reduce the discomfort, okay, to support and prevent relapse and further treatment. So termination is very mutual decision. The family should also be involved. There is no specific termination regime. We down titrate very slowly over weeks to months. And then if after a drug-free period, also the person is insisted that they come and meet us so that they do not relapse. And if you still want to substitute after few weeks, you can consider adding naltrexone if the center provides the same. Naltrexone is a pure opioid antagonist. So to start naltrexone, at least a 10-day abstinence period is required. The special situations are, of course, missing doses. So these are consecutive days. So if a person misses on day 1, then day 2, he or she walks in same dose. 2 consecutive days, look at the pupils. If there are no signs of illicit intoxication, go ahead, dispense the same dose. 3 or 4 days, reduce the dose to the previous given dose by half. And if the patient returns after 5 days, then he or she is considered a new patient again. New induction regime, starts from 0, go through the induction phase, starts from scratch. So that's the rule. 1 day, no change in dose. 2nd day, again, no intoxication, no change in dose. 3 and 4 days, half the dose. Post 5th day, new induction. So since I said 18 years, what if there are adolescents who are stuck with opioids below 18 years? You have to carefully titrate it. If there is a long drawn use of say 1 year or more, discuss with the family, see the possibilities of making this person visit the OST clinic and consider OST under these special circumstances as well. For female users, we have to make sure that the center is female friendly, because again, in female users, the risk is they sell sex. So if a female user meets a male user during his or her period of taking in the OST, then they establish contact there, then they're going to sell sex, and it's going to be further complicated. So what we usually recommend is female users get a separate time and male users get a separate. The consideration is, again, once you have a female user, identify his or her potential female partner and ask her to bring in her partner for treatment as well. I'm sorry. For pregnancy, no contraindication. A person who has already started on OST will continue the OST through the pregnancy. While during the 3rd trimester, due to hemodilution volume overload, the person might require an extra dose from the usual maintenance dose. And during the delivery, we have to tie up with the pediatrician and arrange for neonatal abstinence syndrome management. Descriptive protocol is available on the MOHFW website. This is the last slide. The most recent use that I get to see is Tapentadol, which is a modified opioid like Tramadol. It has both mu receptor agonist and noradrenaline reuptake inhibition. So it's prescribed for chronic pain again. So we have to evaluate these people like any other opioid user. But these are small time users, like 6 months users. So if you have these people, evaluate them correctly, get the blood works done. Do not immediately push buprenorphine. Please see if you can buy their trust and make them come every day. Handle the withdrawals, like you use paracetamol for the pain, use CPM for the rhinorrhea, use ondansetron as an antiemetic, use atropine-based antidiarrheals to cover all this. And within a week, once they're completely abstinent, start the naltrexone. So naltrexone at a dose of 50 milligram per day should do good. While you have to look at comorbidities like, injection site abscess, which is there for the other people as well. Make them tie up with an STI clinic, look for the viral markers. So all IDUs are have a potential for hepatitis C more than HIV and hepatitis B. So hepatitis C is more important. Remember that. So the take-home message, BPN dose is 8 to 12 milligrams in the Indian setting, 40 to 60 milligrams of methadone in the Indian setting. And if anyone wants to maintain BPN at their clinic, there is triplicate register, right, like we maintain for methylphenidate. So the patient gets a copy, we have a copy, and we have to maintain a register for the government whenever they ask. So private players can also take that BPN. It is available under certain trade names. An opioid withdrawal, usually uncomplicated. We can do an OP treatment, does not require an inpatient continuous monitoring like we used to fear. Screen for HBsAg, HIV, and sorry, I missed the HCV infections. Get the family support. And for tapentadol, you can consider naltrexone 50 milligrams. So these are my references. Thank you very much to all of them for their patient listening. If I've overdone 20 minutes, I really regret the same. Thank you so much.
Ma'am, thank you for the short and crisp presentation, what you have made. And it was a very nice presentation. I think it was very useful to everybody. For the next presenter, Dr. Ronald Roy, about the dissociative disorder in the childhood. The participants are requested to ask a question at the end of the presentation of for both the presentations. And if any questions, you can write in the chat box as already presented as message. Over to Dr. Roy, sir.
Good evening to everyone. At the outset, I'd like to thank for this opportunity, for giving me this opportunity to present in this forum. And because of the time constraint, I'll be rushing through certain topics because it's a very vast topic. But I want to focus on the parameters regarding children and adolescent only. Dissociative disorders in children and adolescent only. Okay. On the outset, on the overview, I want to touch upon the history and structure of mind and the nosological differences in DSM and 5 and ICD-11. Then I would like to move on to dissociation as explained as etiological factors, moving towards neurobiological perspectives. Then about certain common clinical features in presenting in children and adolescent, and I'd like to focus on the assessment, treatment, and management approach to a child or a adolescent who presents with such kind of symptoms. Okay, very short. I'll rush through the history. These are the words that come up when we try to read about dissociative disorders in the past, the future. In the past. The history throws out John Martin Charcot, Babinski, Perry Janet. Then came Sigmund Freud and Joseph Breuer's studies in hysteria, and all were actually baffled by the presentation of symptoms, because that was a time where the realm of symptoms of hysteria was growing out, and the ideology of demonism was transferred into a religious ideology and then into a practical and medical realm, right? So first it was Freud who found and named that the symptoms are actually intrapsychic conflicts converted into a medical symptom. So a very brief thing on the unconscious mind, the topography of mind. As you all know, it contains the conscious, subconscious, and unconscious. And the conscious deals with the thoughts and perceptions, and the subconscious, the preconscious deals with the memories and stored knowledge, while the unconscious deals with all the instincts, right? Sexual and aggressive natures, the unacceptable sexual desires, wishes, urges, and all those things, right? So Freud compared this mind to an iceberg where our conscious mind is just the tip of the iceberg. So it happens to collide with these topographical parts of the mind where ego, id-ego, and superego play. So ego is the place where it plays over mainly towards the conscious. It works on the reality principle. Id is where it works on the pressure principle, and this superego is works on the morality principle, and ego is the balancer here. So just to know about these things would give an idea about what dissociation is. So dissociation actually means is to bring apart, split off, or disconnect elements that have something in common. So what the all the persons who found that it represented the unwanted emotional distress that was suppressed in the unconscious, what we showed earlier, in the form of medical and unexplained bodily symptoms. So they did not find any medical support to these bodily symptoms. Then they found out that the reason can be emotional distress, right? So this could be presented in various ways. This can be presented in as disruptions in memory, consciousness, identity, and or perception of the environment, or disturbances in sensation, movement, and other bodily movements. So as Freud said, it is the unconscious feeling which is converted into a physical symptom. That is called as conversion, he said, and that was the primary gain. That was the causal system, the basic cathartic relief of the basic symptoms. And secondary gain was always the advantages that follow from having the sick code. For example, if a child actually loses speaking, right, the child has extra attention and nursing and special concentration, and because of that, the reinforcing mechanism helps in maintaining these symptoms to recur in future. So that is a very specific sign called as labile indifference, where the person who has expressed the symptoms will become detached and unemotional with a calm attitude, lack of concern with probably a severe illness going out, but they are actually very calm inside. This is called labile indifference. Coming to the nosological differences, I want to point out certain things that have come up, right? One, initially, for example, initially it was DSM-4-TR and ICD-10. It was mentioned as conversion and dissociative disorders, where ICD-10 gave an idea of the umbrella of terms. It comes under anxiety, dissociative, or stress-related disorders, where dissociative disorders come out. But when it comes to DSM-5, right, DSM-5, they found out that they made two main changes, the main criteria. One was that it was earlier told that the patient must have a psychological stressor, but it was not so in DSM-5. And also the patient must be determined as not feigning to rule out cases of malingering or factitious disorder. But that is also is not a must criteria in the newly formed DSM, and it has been followed in the ICD-11 also. So ICD-11 actually, recently the whole version came out, right? The ICD-11 gives an idea of the dissociative neurological symptom disorder just as equal to DSM-5, where they mention functional neurological symptom disorder along with the other dissociative disorder. So I'm just touching upon these things. So coming to the etiological theories, right, I want to give an idea that all the previous studies and research pointed towards the stress system. So this was a model where it was found this is a stress system model for functional somatic symptoms that include dissociative symptoms, where 4 or 5 systems are in interaction and overlay. The main systems are the HP axis, the autonomic nervous system consisting of both sympathetic and parasympathetic, the immune inflammatory system that is coming up, and the brain stress systems, including the circadian clock. So there is a motor system which is actually between the interplay between the brain stress systems and the autonomic nervous system, that is the place where the motor symptoms in dissociation comes out. And the pain system also, in cases of chronic pain disorders or dissociative pain disorders, right, where the brain stress systems and the immune inflammatory system interact, where the pain system comes out. And this is a very simple model to understand what are the systems that are at play. So I was talking about this trauma-genic basis of dissociation, right? So there are two basic theories that is going on. One was before, where by psychoanalytic theory, Freud said that there should be a significant trauma antecedent to this dissociation, and it should be a major mediating process. There should be a major mediating process there, but that caused the repression of unconscious conflicts into conversion of anxiety into physical symptoms. So these were the things that actually was put forth in the form of trauma-genic basis. But moving on to neurobiological perspective, the stress systems that involves gives an idea that effects of prolonged stress, trauma, gives permanent alterations in the human brain. It is exhibited by these findings in newer neurobiological concepts. One, there was pathological HP axis response with lower cortical response. That was the reason for dysfunctional, this adrenal response and feelings of passive fear in cases of dissociative symptoms. Second, there was a pathological sympathetic and catecholaminergic response with arousal response. That is why with continuing stress responses in the earlier traumatic stage, in the childhood stage, even with minor triggers in the future, the child or the adolescent, what they'll get the symptoms again and again and again. And the parasympathetic nervous systems are involved in persons with in persons having this childhood trauma in the form of sexual abuse, emotional abuse, and neglect. So all these things point out that there are not only these dysfunctions in these axes and systems, but also functional abnormalities where there is a greater right-sided brain activity because of the disconnection between the two hemispheres, and because of this there's a high-end activity in areas of emotional arousal. And this is very similar to the neurobiological concepts seen in other stress-related disorders like PTSD and other disorders also. So there are obviously a decreased left prefrontal activity, earlier maturation of prefrontal cortex. So what happens when the child experiences these kind of abuse earlier in the stage, and if that kind of experiences come again and again and again, this causes permanent alterations in brain structure and function. And that major studies in these areas would help us to understand the neurobiological mechanisms behind dissociation. So earlier the stress may alter the cortical neuronal development during the developmental stage and even after the stages. So I told you in children and adolescents, the dissociative disorders are disruptions or discontinuity in the normal integration of one or more identities, sensation, perception, affects, thoughts, and all kinds of bodily movements or behavior. And research shows that 5 to 14% among the general hospital referrals to psychiatry and to child psychiatry or to pediatrician can have one or the other dissociative symptoms as presenting symptom. So usually onset can be at any age, but usual onset in children and adolescent stage is in the late childhood to early adolescence and adulthood. So prevalence among sexually abused and maltreated children are very high, up to 73%, and in inpatient adolescent cohorts it was ranging from 23 to 40%. So according to ICD-10 nomenclature classification, the onset usually it is acute between the puberty and the early adulthood for dissociative neurological symptom disorders, where the motor, sensory, and the other symptoms come out because of the dissociative phenomenon. So onset in early childhood as early as 3 years, as we noted, it has a transit or persistent course in two ways. It occurs, as I said earlier, and it is almost always associated with a traumatic life event, or in case of children with minor illness or physical injury. So commonly, non-epileptic seizures are the most likely to have their onset earlier in lifespan than the other motor symptoms in children and adolescents. So we know about the positive and the negative prognostic factors. Obviously, younger age and acute onset is a positive prognostic factor. Still, because of the developmental perspective, the more the age and the frequency of episodes the person has, the prognosis goes down. So being a monosymptomatic presentation has a good prognostic, is a good prognostic factor, and to opposite to it, a polysymptomatic presentation is a bad prognosis because many factors are at overplay. And children or adolescents having a good above average intelligence and short interval between symptom onset and initiation treatment has a good prognostic factor. That is the reason why it is imperative to earlier identify these kind of symptoms in children, so that the whole point of addressing these features would give us a good positive feedback. So I'm not going to go into all the motor symptoms, but two of the symptoms are very, very common in children and adolescents. One is gait disturbances and another one is non-epileptic seizures. And rarely other forms of dissociative disorders are also present, but these are the two things that are very most common and most frequently presented in children and adolescents. Both in Indian research also it is said so. Psychosocial stresses around these traumatic events are commonly bullying, school-related stresses, family conflicts, adolescents co-occurring mood disorders and dissociative, and in adolescents there are co-occurring mood disorders, anxiety disorders, and transient post. In dissociative amnesia, it is difficult to detect in children. It is not very common and is misinterpreted as lying and denial. In trance and possession trance disorders in children, they do not present as such in adults, but as vacant staring or talking to themselves loudly in different voices. And in adolescents, as nervousness and excitability, as persons have, and they are seen as persons having behavioral or emotional dysfunction. Depersonalization, derealization disorders are onset in childhood, and it usually a mean age onset is at 16 years, and common symptoms occur at that period only. So dissociative identity disorder and are very, very rare, but the earlier the episodes of abuse or trauma in children can cause earlier initial identity changes. Because these identities are not fully developed in children and adolescents, they will not have the ability to separate between personalities. So usually they'll be presenting as other symptoms, or be diagnosed as having childhood mood disorders or childhood depression or childhood emotional dysregulation or adolescence kind of thing. But with adequate treatment, children tend to have better prognosis than adults in dissociative identity disorders. So I told about two symptoms, right? One is gait disturbance, another one is dissociative seizures. In motor symptoms, one we call this as aesthesia abasia, or any kind of abnormal gait disturbances. Usually it worsens with calling of attention. And this aesthesia abasia is a wildly ataxic, staggering gait where grossly irregular, trunky movements are seen. Usually reflexes are normal, EMG is normal, CT, MRI is normal. These are the other dissociative disorders where the tests can be given to identify the conversion findings or differentiate it from other organic conditions or primary medical disorders or neurological disorders. I'm not going to go into it. And very one or two tests I want to just tell you. One is this positive motor signs. They say there are many such signs, but I just wanted to tell you about one or two things. One is about this face hand test, where a person having a right upper limb paralysis, for example, if the patient momentarily exerts sufficient strength to deflect a falling hand. When we put a hand over a face, right, the person will have sufficient strength to deflect from hitting her own face. This indicates that it's a psychogenic paralysis. This is one of the signs. And in functional gait impairment, I told you, right, the person they have this aesthesia abasia, right? They stagger, they balance momentarily, but appears to be they have great danger of falling. However, catching themselves at the last moment, they never injure themselves. So clinical features of non-epileptic seizures, I just want to tell you a few points where differentiation of two seizures is difficult, because 1/3 of pseudo seizures have coexisting epileptic disorders in children and adolescents, and commonly in adolescents. Commonly, tongue biting, urinary incontinence, and injuries are after falling is absent. All the reflexes are retained. EEG is usually normal, and no post-seizure increase in prolactin is seen. Identification of unconscious, identification or a role model in cases of these seizures are very common in this season, because in the family or friends, they have this identify a person as a role model, and their symptoms being put upon them as these symptoms. So these are the differences between dissociative convulsions and epileptic seizures in pre-ictal phase, ictal phase, and post-ictal phase. As I already told you, these are the basic variations in differentiating between dissociative convulsions and epileptic convulsions. One or two things we've already discussed. Okay, so I'll focus on the last part, what to do when we are approached with a child who is, if you have ruled out all the possibilities of a medical or a neurological diagnosis, right? They are presenting with a symptom, how to approach. So keys to assessment lies in a comprehensive medical, neurological, and mental status examination, ruling out physical, neurological, primary psychiatric disorders that could explain the symptoms. In children, it is very common, children, adolescents, that primary psychiatric underlying disorders can mimic as dissociative disorders also. And we find and establish other comorbid physical or neurological psychiatric disorders if present. In case of adolescents, there are very many mood disorders and anxiety disorders that can present as dissociative disorders. So though I say that all these things will give us a clarity, the diagnosis of dissociative disorder should not be based merely on the absence of the objective signs of physical or psychiatric disorder. This is the point where the DSM-5 gives us the nomenclature, where in the criteria they have left out the point where there is not necessary to have an identifiable stressor, and also patient not feigning also is not a criteria there. So what to do next? Assess the biopsychosocial context of the child and family with the onset of dissociative. When did it start, right? Then go on to find out the family functioning and the parenting style. Then find the psychiatric or physical disorders in the family, any role models, person with seizure disorders, patient with mental disorders, all those things. Then come to the child. Assess the temperament, coping mechanisms, and assess personality traits and interpersonal relationship among adolescents also. So these are the basic points we should keep in mind to assess these children and adolescents. So coming on to the investigations, we already know the to rule out common medical neurological disorders mimicking as dissociative disorders. Obviously, EEG for a seizure disorder, IQ test, urine drug screening for any substance use to rule out the cause of symptoms due to the cause of substance use, neuroimaging and blood tests as and when necessary. So what are the psychosocial factors? Already told you, it is individual, family, and environment. All three has a overlaying influence on the giving a traumatic experience to these children and adults. So obviously the temperament, coping skills, intellectual functioning, and other psychiatric illnesses. In family, the parenting styles and all those things, substance abuse in the family, the disharmony in the family, environmental comes to bullying in the schools, academic stress, so school phobias, critical teachers, and abuse in all forms and things. So when it comes to objective findings in respect to younger population and children, these are the tools that have been used. This is different from the other tools used for the adults to diagnose dissociative disorders. So our self-assessment tool, adolescent dissociative experience, these are scales that can be used. I'll be giving a link to that later. And obviously, differential diagnosis, common physical disorders rule out true epilepsies, other movement disorders like chorea, atosis that can happen in children and adolescents. Multiple sclerosis can present as symptoms that could mimic dissociative symptoms, and other musculoskeletal disorders also. And differential diagnosis, common differential diagnosis is two. One is factious disorder by proxy, where the caregiver intentionally produce symptoms in their child by make them to assume a sick role. And malingering is obviously symptoms are feigned to obtain an incentive or avoid punishment. If in case we can find the reason or the incentive because of the symptom, we can rule out accordingly. But psychiatric comorbidity, oppositional different disorder and conduct disorders, ADHD and intellectual disability are very commonly comorbid in patients presenting with dissociative disorders, making it very difficult to diagnose specific dissociative disorders in these patients. So screen for all age-appropriate psychotic disorders in the child when they come with. So coming to the last part, the treatment part. There is a model called the Silberg model. They found out that understanding the symptoms, dissociative symptoms underlying the psychoanalytical perspective and neurobiological perspective, there are 3 stages. 1 is stabilization, 2 is trauma processing, and 3 is integration. First, stabilization, where we sit down with the patient and the parent, child and the parent, they educate about the trauma and the dissociation. If we could find what the trauma, the conflict is also, we can sit down with the child and understand and tell them that this is what is causing this dissociation. So dissociation motivation, the understanding why it is tied to this trauma. 2. Third, understanding the hidden parts of the cell, to make the child understand the hidden parts of the cell, and to teach them certain techniques and behavioral management, where we give them relaxation techniques or other alternate things where they could help to come out of this traumatic by giving them coping strategies or telling them about other strategies also. And the second part is traumatic processing, understanding what the triggers are, because in children and adolescents, the triggers can be very, very trivial. We can't assume that the triggers can be a very high trigger or a very identifiable stressor in this case. And at the last point is to integrate and to make them ready for a new life after they come in terms with the symptoms, and to how to cope with it, and to help the child encounter a new life with the newly available symptoms. So this is a basic model. And what else we can do? 1, this child parent psychotherapy. Sit down with both the parent and the child, tell them about the common causes that has led down to this thing, and the 3 components of this therapy helps to maintain future or to stop future episodes in the child. Affect regulation techniques, obviously, to make them understand, identify and express their emotions properly, tolerate them, and to interact with the world outside. EMDR is very common in advanced cases. This eye movement desensitization reprocessing can be done. It helps in the trauma processing stage, because that is the very difficult stage to cross over in case of children and adolescents. Actually, no medication targets dissociation. No medication comes specifically to help in dissociation, but pharmacotherapy may be used to reduce symptoms that interfere with functioning, for example, sleep disturbances and other factors. So, as I already told you, the treatment factors are the acute treatment, reassurance, relaxation, form a therapeutic alliance, realistic solution to the problems, find out about the sick role in the secondary grains, give them a positive behavior, healthy coping, and also treat the comorbid physical and psychiatric disorders. If it is a chronic condition, family-focused cognitive behavior therapy at regular intervals, even with or without symptoms, is very important. So what is the key points in psychoeducation? It should be...
Sir, I said time is...
Yes, 1 minute, last slide. The first point, the important point is to be acknowledged that the child has real symptoms and sufferings, and the reasons could be psychological, not physical, and harmlessness should be said to the patient and the child, because they'll be very worried about the symptoms apart from this Labellian difference, and the other things should be done in psychoeducating the child. So obviously the behavior management involves all the things I've already discussed. I just want to give a gist of what happened in the first. If a symptom suggests a dissociative disorder, investigate, rule out all the organic disorders that could have caused the symptoms, rule out physical illness, comorbid psychiatric or physical disorders, and assess all the family parenting styles and temperaments, then make a diagnosis of dissociative disorder. Hospitalized, if the symptoms are severe, there is treatment resistance. So, and what I told you, the treatment consists of acute and chronic part, psychoeducating the family, behavior management of the child, and in cases of chronic symptoms, CBT is the basic. So, in a nutshell, developing a more holistic mind-body approach in diagnosing and managing dissociative disorder in children and adolescents is very important. It should include all the multiple specialties involved, including pediatricians, psychologists, neurologists, everyone. Moving on from a trauma-genic perspective to a neurobiological perspective, will identify in managing disorders very better in the future. Earlier identification can prevent iatrogenic damage to children, because children will taking so much of drugs and without giving it proper diagnosis of thing. These are my references. Thank you for the opportunity. Though I've rushed through all these things, it's a very detailed thing. Thank you. Thank you.
Thank you, sir. Am I audible?
Yes, sir. Yes.
Yeah. So thank you for that detailed presentation, sir. You have nicely gone from history to various problem aspects and then the current dissociative aspects. So the challenging part in dissociative disorder, especially in childhood, as I already mentioned, to lies in with the neurology. So where it is directly, whether it is a neurological seizure or it is a pseudo seizure, whether the anti-epileptics to be continued or should be stopped, that's a very different, difficult question. When family members ask, we need to answer those things. So I think both presentation is now open for discussion. Any questions?
Sir, am I audible?
Yes, yes.
So I'll try to answer the questions in the chat box.
Yeah.
So NDPS approval, I'm not sure, but what as a private practitioner, we have to maintain the triplicate records and just follow the NDPS Act, which is available on the website to download and go ahead if you want to dispense opioid substitution therapy. And also, I would like to mention that TANGSAC's Tamil Nadu AIDS Control Society is doing a wonderful work in Thoothukudi and Coimbatore, helping them establish OST centers. So if anybody wants to start an OST center in the government sector, they can approach TANSACS for further guidelines. On tramadol use, like I said before, if you are a private player, we can still do it at the private clinic, which I currently do. All you need to do is establish the rapport. The last slide showed that you establish rapport with the patient, be it tramadol or tapentadol. Give them reassurance that they can come to the clinic every day and they can describe their symptoms, so that we do a day-to-day evaluation of the level of withdrawals that they're going through. Medicate them adequately with paracetamol, chlorpheniramine maleate, antidiarrheals, and antiemetics. Within 5 days, usually the tramadol or tapentadol withdrawal can be tackled very easily on an outpatient basis, and then we can start naltrexone. We need not refer every patient to a OST center or to the nearest GH. That's number one. And if possible, if the patient is willing and you have a setup where you can admit and monitor, well and good, because one of them asked, why don't we admit and treat? There is a lot of stigma still associated with managing opioids as an inpatient, because look, you don't know the viral load status of the patient. So when you're drawing blood, if you follow universal precautions, you're wearing 2 gloves, you're wearing a mask, then the patient feels that he or she is being treated differently when compared to other patients in the ward. So there are a lot of such ancillary issues which deter the patient from getting admitted into a ward and seeking help. So that is why an outpatient-based treatment is comparatively more successful in terms of opioid replacement, opioid substitution. That's all. If I have left anything unanswered, I'll do that again.
Dr. Swetha, Dr. Swetha?
Yes, sir.
For the patient with opioid withdrawal, does they need this clonidine substitution? Because initial withdrawal symptoms, whether there's a need of clonidine or this buprenorphine naloxone alone is enough.
Sir, clonidine, if we are giving, it requires that serial BP monitoring. So that's when, if you can admit the patient, we can use clonidine. Clonidine dosages have been mentioned from 0.5 milligrams. But for this clonidine administration, we require not an ICU, but at least a ward setup where the BP can be monitored every 2 hourly once, because the BP suddenly drops with an alpha agonist. Otherwise, if we are managing on an outpatient basis, then I think buprenorphine should do the job.
Buprenorphine alone is enough to overcome the withdrawal?
Yes, sir. Yes, sir. It will take care. Additionally, if we want, we can use ondansetron for as an antiemetic and atropine-based antidiarrheal agent if the patient develops diarrhea, and chlorpheniramine CPM for tearing.
Do we need a special certificate, for example, to keep a stock of this buprenorphine naloxone drug?
Yes, sir. It's an NDPS drug, so we require an approval.
We need the narcotic license, because the pharmacy,
yes, sir.
pharmacy license. Is it possible to dispense with a pharmacist license, or we have to get a?
No, we have to get a special license for dispensing buprenorphine in our clinic, sir. And again, triplicate registers have to be maintained, where on special license is required.
In our operation theater, we have an OT in our hospital. So OT, because we have a surgical unit is there for the drugs like Methadone and other thing, we are getting a license. We have a narcotic license. Similarly, for a psychiatric setup, to deal with these withdrawals and opioid withdrawals, to keep the stock, whether we need that kind of certificate.
Yes, sir. We need a narcotic license to keep BPN.
It has to get it from the collector, district collector.
Yes, sir. Yes, sir. Yes.
Without getting a license is an offense.
Yes, sir. Sorry, I didn't mention that. We cannot make all private players cannot just buy in stocks. Actually, the distributor himself will not give. The moment we ask for BPN, we have to give our certificates and show that we have a license from this date to this date. The validity will be checked, and then only he will himself distribute it.
Ma'am, there are some other questions. Any experience with the Tapentadol use as IV use? Any
yes,
IV?
Sir, yes, I was talking about Tapentadol IV use only. Sorry to mention, but this is a brand called Tidal, which is available easily in the market, and it is a 50 milligram, 100 milligram tablet. Painkiller nu keta first adhaan kudukranga. So they break it, they crush it, use it with normal tap water or normal saline, whatever you get. Whatever treatment that I had mentioned as CPM, all this is for IV Tapentadol use, not just oral. So the only complication is they might have some blisters in the hand, which might require drainage. So the treatment protocol still remains the same. And we have to, of course, monitor them for HIV and other STDs.
Another question, use of buprenorphine naloxone combination during the initial phase.
Same, sir. Same, because naloxone is a standard dose combination. Naloxone dose doesn't increase. BPN-N brands are probably Adnoc-N. You start with 2 milligram. There is no change because naloxone is being added. So same. You give a 2 milligram crush tablet, ask the person to wait another 2 hours, then another 2 milligram, then another 2 milligram, as long as it is less than 8 milligrams on day 1.
Yes, madam. Idea of adding buprenorphine and naloxone in the single tablet is, for example, if you are dispensing buprenorphine in the government clinic or wherever, what happens? The patient take the buprenorphine from you. If, that will be either sublingual or oral tablet, but they will crush and use mix with some dilute water and something, and they will try to use it as an intravenous injection. So to prevent that only, they have given this. They have brought this combination of buprenorphine and naloxone combination. So what happens if you are taking the buprenorphine naloxone combination orally? The buprenorphine will be active. The naloxone will not be active. Okay. The patient will be having the opioid substitution treatment will be there. When you are taking the same tablet, that is buprenorphine naloxone combination in the IV, what happens? The naloxone will come into act, and it will act as an means it's an antidote. Like means it's an anti-opiate, like opioid antagonist. So what happens? The patient will experience the withdrawal effects. So this cannot be buprenorphine naloxone combination tablet cannot be used as IV, or cannot. That is the main understanding for combining this buprenorphine naloxone. Yeah. Any other question on this area?
Swetha, when the continuation phase, after that the patient is maintaining well, to prevent the craving, shall we give naloxone alone, naltrexone?
Yes. Yes.
Sir, yes, sir. No, but when patient is already on a BPN, we cannot combine it with naltrexone because naltrexone will act as an opioid.
Cannot be given immediately.
Cannot be given immediately. At least 1 week of abstinence has to be done, sir. If the person has stopped BPN, at least 1 week of abstinence period from BPN and illicit opioids, then start naltrexone.
So what happens if the buprenorphine once
patient will develop a severe reactions if you give IV?
Yes. Severe.
What will happen, sir? If the patient is taking buprenorphine and immediately without knowing whether the patient is taking buprenorphine, the body of the patient is having buprenorphine or not. Without that, if you are prescribing naltrexone, what happens? The patient will develop the agonist-antagonist reaction. So to prevent that, what they usually do is, one method is, it means checking the urine of the patient for opioid. That is a very costly. You require the thin layer chromatography technique to assess that. The another understanding is you give the naloxone. Naloxone is a short acting. Naltrexone is a long acting. So when you give naloxone, that is called naloxone challenge test. Naloxone challenge test. So if the patient is already taking buprenorphine for considerable period of time, if you are providing naloxone to the patient, if the patient body is having the opioid, then the patient will experience withdrawal symptom. That is for short period because naloxone is a short acting. There is a short acting. If the patient is experiencing the withdrawal symptom, then it means that the patient's body is having buprenorphine. Means the patient's body is having opioid. If the patient is not experiencing any withdrawal effect, means the patient body is not having any opioid. So once the naloxone challenge test, the patient is not experiencing withdrawal, you can give naltrexone. That is understanding.
Dr. Roy can take some questions there in the chat.
Yes, Roy, sir.
Yes, sir.
In the
One
chat
is, am I audible?
Yes, Dr. Roy.
Yes, sir. They've asked that how long can dissociation be present, even if the symptom persists for more than 1 year? Yes, we call it as dissociation. If we can exclude the other organic causes of that symptom, yes, it can happen. Though the common presentation is a very transient, small episodes, it can happen for years together. And and another question was, we feel a child is depressed in dissociative disorder, should we start an antidepressant? If we are very sure that the person has a comorbid depressive disorder, we can start on SSRIs. Commonly fluoxetine is used, but other studies show that other in lower doses can be used. But usually, if we feel that the primary problem is the dissociative disorder alone, there is no need for antidepressant unless we are very sure of a clinical depressive episode in the patient. If we can find a proper affective episode or a depressive episode, use of antidepressants and mood stabilizers can be done if it is recorded and documented properly.
Sir, there was another interesting question to whether you can give anti-epileptic. What happens if you give anti-epileptic to a patient with dissociative disorder?
Commonly, the main presentation is pseudo-seizures in children, and 1/3 of the patients usually have true seizures. So in certain cases where true seizures is not established or giving anti-epileptics will not be a very broader use. But not many required. Children, yes, that was the point I was trying to tell it. To reduce the iatrogenic damage in 2/3 of the patients, there is no need for that. Patients, when a patient's present with seizure symptoms, the protocol is to start on anti-epileptics, and then only we come and find out that the patient has a dissociative seizure. But even after diagnosing with a patient with dissociative seizure, many patients continue with anti-epileptics, and actually it can be reduced unless there is a confirmed EEG finding or a confirmed diagnosis of the seizure disorder. There is no need for anti-epileptics in patients with dissociative disorder.
Yes, sir. Yes, sir. Any other questions? Or
yes, Dr. So, if no other question, you can wind up.
Sir?
If no other questions, you can wind up.
Yes, sir. Okay, in that case. So again, once again, I would like to thank the Tamil Nadu IPS chapter for providing this wonderful opportunity for sharing this excellent program. I would like to thank all the participants who were here for throughout the presentation, and I thank both the speakers, Dr. Swetha as well as Dr. Ronald Roy, for providing excellent presentations. Once again, I would like to thank everyone for this opportunity. Thank you.
Thank you, sir. Thank you, everybody. Thank you, sir.
Very good
Concluding
presentation. Good presentation, Dr. Swetha Raghavan for OST and Dr. Roy for the dissociative disorder in child and adolescent. And thank you, Dr. Sivaram, for maintaining the time. We are busy with time. Thank you all the participants, and we all meet in the next Enrich webinar. Thank you all. Good night. Thank you, Navi. This was Pharma for providing the list. Thank you very much.